First, I want to welcome you all in a new prostate imaging session. And I would love to welcome at first our international speaker, Professor Giganti from Italy. And I would welcome as well our chairman, Professor Hani and Professor Haytham, Professor Dayasti, and our attendees. And here we start another session in the third International Conference Radiology Imaging of Ministry of Health and Population. We're going to discuss about MRI pathway and vision ahead and the non-invasive treatment of some prostatic lesions. And so we're going to start with our international speaker, Professor Giganti. He's most welcome in Egypt and came especially for us today to teach us and give us some of his priorities. And if Professor, I would like to start, Professor Giganti.
Thank you for the kind invitation, and good afternoon, everybody. So in the first talk, we are going to discuss the importance of image quality in prostate MRI, and I work at University College London. So first of all, we know that MRI is really important in the diagnostic pathway of prostate cancer, and this is really important because it helps us avoid unnecessary biopsies and also can influence how we do biopsies. We have seen also that MRI, the quality of the images varies between centers. And so this is really important that we perform it in a sufficiently high standard. So in this slide, you can see the history of prostate MRI, basically. So the first study on prostate MRI is from 1982, so more than 40 years ago. And then you can see the different timelines here and the achievements that have been made. For example, the first study on DCE sequences with the contrast is from 1993, and the first study on diffusion is from 2002. This is a scan from 1987. You can see that this is how a prostate looked like nearly 40 years ago. But today we are much luckier because we have a good quality images like this one. So you can clearly see the difference, right? As radiologists, we are very lucky because we have the PARAS document that tells us how to acquire a good quality prostate MRI on the three different sequences, T2, diffusion, and DCE sequences. And here in this slide, you can see the different technical parameters that we should look for and apply when we do prostate MRI. For example, for T2 weighted imaging, it's really important to have a slab thickness of 3 millimeters, for diffusion 4 millimeters or less, and for DCE sequences 3 millimeters. And then it's also important, for example, for T2 weighted imaging to have an axial and coronal or sagittal plane. For diffusion, it's really important to have a high B-value sequence. And for DCE sequences, it's really important the temporal resolution is up to 15 seconds. It is also really important to have a good quality image to do the prostate MRI not straight after a biopsy. We should do that before the biopsy. If we have a biopsy, then we will see this artifact that is called the post-biopsy artifact, where we have a high signal, so white on the T1 weighted images in the pre-contrast sequence, like in this case. So we should wait, according to the PARAS guidelines, at least 6 weeks or longer between biopsy and MRI. We published a consensus meeting with the ESUR and the ESUI, where many experts convened and explained the most important topics for prostate MRI, and image quality was one of these. You can see here in this table that it is really important to check the quality and the reporting of the imaging. It is really important to assess our performance as radiologists with histopathology, and also it is really important to adhere to the technical requirements of the PARAS version 2.1 guidelines. And this is the reason why in 2020 we created a dedicated scoring system from the precision trial called the PI-QUAL, Prostate Image Quality. And this is the version 1. And in version 1, basically, we had 5 different scores from 1 to 5. And a score of 1 and 2 meant that the quality was suboptimal. A quality of 3 meant that the quality was sufficient. And the score of 4 or 5 meant that the quality was good. In order to get your PI-QUAL score, you had to look at the different technical parameters here that we have seen in the PIRAS document for T2 diffusion and DCE sequences, but also some visual assessment, more subjective, for example, the presence of the seminal vesicles clearly delineated, the ADC map, and the capsular vessels on DCE sequences. And here again, just to highlight the importance of PI-QUAL 1 and 2, low quality, PI-QUAL 3, sufficient quality, we can rule in but not rule out all significant lesions. PI-QUAL 4 or 5, very good quality. We created an educational review that is open access, so if you are interested in the topic, please download it, where we explain step by step how to get good images. For example, here you can see 3 acquisitions on an axial, coronal, and sagittal acquisition on T2 weight imaging of good quality, where you can clearly see the transitional zone and the peripheral zone. In terms of the anatomical landmarks that we have to look at, if we want to assess the quality, the first thing is the pseudo capsule here, we can clearly see here, and also the neurovascular bundles on the left here. So you can see here the different anatomical structures in a very good way. We also have a very good delineation of the seminal vesicles, the right and the left, and the urine in the bladder. So the quality of this scan is again good. Also, we should look at the presence and the visibility of the ejaculatory ducts, the right and the left. If we can see them, the quality of our scan is really good. And finally, on the coronal acquisition, we have to look for the external urethral sphincter, which is this hypointense black stripe, and if we see it again, the quality is really good. Of course, we have to avoid to have artifacts like motion artifacts here or artifacts from metallic implant in the right hip. In terms of diffusion, as you know, we have the high B-value sequences and then the ADC map. So we look for the presence or not of tumor, which is hyperintense on the high B-value sequence and hypointense on the ADC map. It is really important to get at least 2 B-values up to 1000, from 0 to 1000, in order to create our ADC map. And then a dedicated high B-value sequence, like in this case, where we can clearly see the lesion in the left anterior horn here that corresponds to this area of low signal on the ADC map. So 0 to 1000 to get the ADC map, and then a single dedicated sequence, a high B-value, to see the lesion. Here you can see an inadequate and an adequate ADC map, where we can clearly see the peripheral zone and the transitional zone. Of course, we have to avoid having artifacts like this, where we have metallic implants here, so basically our diffusion weight imaging is non-diagnostic, and also some artifacts on rectal air here. You can see that the left part of the prostate is not visible. Finally, for DCE sequences, it's really important to have the pre-contrast T1 weighted imaging, as I said before, where we can see some artifacts, in this case, for example, from post-biopsy in the right anterior horn. And it is also really important to have fat-suppressed images, like in this case, because the hyperintensity of the structures and the lesions are more clear. The temporal resolution should be 15 seconds for PIRAS version 2.1 guidelines. In this case, we have a temporal resolution of 30 seconds, which is not adequate because we are not able to see the tumor that has an early wash-in and an early wash-out. If we have a good quality MRI for DCE sequences, we will see the capsular vessels very clearly here, as you can see here on the left, but also the pudendal artery in the Alcock's canal. So if we see these 2 anatomical structures, again, the quality is good. Of course, we can have artifacts also on DCE sequences, so metallic implant in the right hip and motion artifacts on DCE sequences. So PI-QUAL is changing the way we look at prostate MRI. For example, in this study from our colleagues in Cambridge, it has been shown that if you have a high PI-QUAL score, good quality, you have a higher number on negative MRI calls. We feel more confident in saying that there is no tumor on MRI. And also, if you have a good quality MRI, you have a less decreased number of lesions that are biopsied. So higher PI-QUAL scores are associated with decreased uncertainty in giving a negative MRI. And this also has a very important, is a very important aspect for biopsies, because as you can see here, if you have a good quality MRI, PI-QUAL 4 and 5, the detection rate of clinical prostate cancer is higher. And also the positive predictive value, as you can see in this graph. So better quality, higher positive predictive value. PI-QUAL is also really important to evaluate the presence or not of extraprostatic extension. As you can see here, if we have PI-QUAL and a high PI-QUAL, good quality, we are more confident in saying that there is or there isn't extraprostatic extension. And this has also been validated in 5 different European tertiary referral centers, where using this regression model, they have shown that with the low quality scans, they had a higher rate of upstaging after radical prostatectomy. PI-QUAL is a multidisciplinary approach. It's not only us as radiologists, but it's also work with the radiographers, the physicians, and the technicians. So it's really important that all together we work to improve the quality of our scans, and we know what PI-QUAL is. We can teach how to use PI-QUAL, as you can see here, between non-experienced and experienced participants. We gave a teaching course to some attendees in Paris, and we saw an increase after teaching the red curve. So basically there was an improvement on how to assess image quality using PI-QUAL from 0.59 area under the curve to 0.96 with a significant p-value. We also look at the importance of image quality around the globe. So basically we ask centers taking part into the PRIME study, that is a study comparing multiparametric and biparametric MRI, to send their images before starting the study. And we look at the quality, and we saw that actually after with minor changes, for example, the in-plane resolution on T2, the high B-value sequence, or the temporal resolution DCE sequences, we could improve the quality up to 98% of the centers with PI-QUAL 5 and only 2 PI-QUAL 4. And we started with some centers that were scoring PI-QUAL 3 sufficient image quality, meaning that it's easy and it can be done. We can change the way we do our prostate MRI. PI-QUAL has gained a lot of attention, a lot of editorials also from the urologist, and this is the reason why we gather all together and we created the version 2, that is this one, again open access, so feel free to download it and look at PI-QUAL version 2. PI-QUAL version 2 is easier than PI-QUAL version 1. We have only a few technical requirements. It's really important to have the 3 millimeter cutoff for T2 and DCE sequences, and for diffusion it's really important to have the high B-value sequence. We have now only 10 points. And here you can see the different points that can be given to T2-weighted imaging and diffusion-weighted imaging, and DCE sequences play only a minor role. It's either a plus or a minus, and the PI-QUAL score now is a 3-point scale, 1, 2, and 3, where 1 means non-diagnostic, 2 sufficient, and 3 good quality. And the other big change here is that we can apply PI-QUAL version 2 both to biparametric and multiparametric MRI, as you can see here. There is, of course, a combination of different scores. I'm not going to go through this into too much detail. You can find it online in the paper. But as you can see here, with a different combination, we can get a final PI-QUAL score that can be used for the multiparametric or the biparametric MRI. All the images should be evaluated together. We should also include a separate score for each sequence, so we know in which sequence we are not doing great. And also, it's really important, where we do have a non-diagnostic scan, we should not give a PIRAS or Likert 3. Otherwise, this means that we are just giving an equivocal lesion just because the quality is bad. This is the comparison between version 1 and version 2. So it's much easier now, 1 to 3 scale, 10 criteria, and can be applied both to multiparametric and biparametric. So in conclusion, image quality is really important. It's the first important step in the chain of the MRI diagnostic pathway. It is really important that we are aware of the PIRAS version 2.1 technical recommendations, and we should assess image quality during acquisition. And then we have other, of course, steps in this diagnostic pathway, but as you can see here, image quality is the first one. So the 3 questions that we should always ask ourselves are: is the quality of my examination adequate? Is the quality of my reading good? And is the procedure of the biopsy okay? And for this, it's really important to discuss the cases with your local urologist, and also to know how many times you are calling PIRAS 3 or 3 lesions that are not significant. PI-QUAL version 2 is here to stay. And again, the most important thing is that this is a global effort. We have to work all together to improve the quality of prostate MRI across the globe, and that we collaborate within the urologist. Thank you.
Thank you, Professor Giganti, for the very nicely illustrated presentation. And I would like to ask if anyone from the floor has any questions. Yes, please. Yes. Do we have a mic here?